Good afternoon. It is a pleasure to be here, and thank you, Dr. Jakobsen, for your introduction. Okay, I'm going to share with you some of my experience in over a decade of routine clinical use of Desflurane in a variety of normal and high-risk patient populations. And I think some of the things that I particularly want to highlight during my time are the predictable recovery that one has with Desflurane, both of cognitive function as well as return of protective airway reflexes. I also want to highlight, besides the advantages of Desflurane, the challenges of Desflurane. And I think, as Dr. Jakobsen says, if we understand the pharmacology of the drug, we will understand how to use it effectively and take best advantage of its unique characteristics. What we see here, and this is Eager's work, is the length of time it takes to eliminate 90% of an anesthetic in the vessel-rich group in the context of the length of time the anesthetic has been administered. And what we see is that, for example, with isoflurane, after 2 hours of administration, it takes more than 1 hour to eliminate 90%. We see over time with sevoflurane, there can be some accumulation, particularly in longer cases. On the other hand, with Desflurane, we see that the length of time to eliminate 90% in the vessel-rich group is almost independent of length of time of exposure. And what this means is, compared to other anesthetics, when one turns it off, the time to awakening is very predictable. Number one. Number two, from a potential safety perspective, we know that once this drug is turned off, shortly thereafter, we will have patients back to normal function in any number of organ systems. So this rapid return of cognition is important. It's important to patients. It's particularly important to families. I was just in the previous session here on anesthesia for the elderly, and this is obviously a huge concern in this group. Return of normal respiratory function is important in obese patients, important in elderly patients, and particularly the return of normal airway protective reflexes. Moreover, we know that volatile anesthetics in general, and Desflurane specifically, have some advantages to intravenous anesthetics, particularly if one is not using neuromuscular blockade. And in this study, we see that patients who receive Desflurane are less likely to move during surgery in the absence of neuromuscular blockade than patients receiving isoflurane, and much less likely, this is a trend here, much less likely to move than patients receiving propofol. And again, some would consider the ability to maintain a patient breathing spontaneously to be a valuable thing to do. We also know that Desflurane is the least metabolized of the volatile anesthetics. And as Dr. Jakobsen explained, in modern times our patient populations are compromised, have compromised organ function. To have a drug that is very minimally metabolized is reassuring to me. Now, success with Desflurane requires an understanding of its pharmacokinetics, an understanding of the potential problems one can have with rapid increases. If one rapidly increases Desflurane above 1 Mac, one can have tachycardia or airway irritation. But the main point I will make here this morning is that one should not need to go above 1 Mac. If one does not go above 1 Mac, you are very likely to avoid these problems, number one. And number two, I think Desflurane is different from other halogenated anesthetics because of its rapid wash-in and wash-out. There is not the need to overpressurize like we might do with older halogenated anesthetics. On the other hand, at the end of surgery, when patients are waking up, there is very rapid elimination. There is not the need to turn it off in advance during longer cases to the same extent like other anesthetics, and this is particularly true if you have a patient in whom neuromuscular blockade is going to be reversed. If it takes 15 minutes for full reversal of neuromuscular blockade, you want to make sure that you don't turn off the Desflurane until patients have had a chance to recover full neuromuscular function. So let me talk some about these issues of tachycardia and airway irritation and how we can successfully manage anesthesia with Desflurane to avoid these and have the benefit which we wish to have, which is rapid recovery. So in this study, we see here, if one increases Desflurane above 1 Mac, you see compared to isoflurane, increases in sympathetic nerve activity. And this can translate in increases in heart rate with Desflurane compared to isoflurane. So again, the important thing to avoid here is going over 1 Mac, and how can we do that? Well, one thing we can do is to use adjuvants, and most of us practice anesthesia using a variety of adjuvants. This is one study using fentanyl, and we see that patients who receive no fentanyl have an increase in their heart rate as the end tidal concentration of Desflurane is increased over 1 Mac. This is blunted significantly by giving judicious doses of opiates. These doses of opiates are fentanyl, and I must apologize, this should be 1.2 mics per kilo per hour infusion after a bolus of either 2.5 micrograms per kilo or 5 micrograms per kilo. But understand that with judicious doses of opiates, you see here, you can go up. Here we are at a Mac, above a Mac of Desflurane, without getting an increase in heart rate. And so that's one of the keys to use of Desflurane, is to combine with adjuvants. Another possibility, and this is frequently used by those of you who use TIVA, is the use of Remifentanil. And when you see here with different target concentrations in the blood, we see with no Remifentanil, this is the MAC bar for Desflurane to block the adrenergic response. With Remifentanil concentration of 1, we see it is cut by more than 50%. With a concentration of 3, it is cut even more than that. So by using reasonable amounts of opiates, we can really reduce the amount of Desflurane that's needed to give patients, avoid the tachycardia, avoid the respiratory irritation, and have rapid awakening. Another adjuvant that some clinicians may choose to use is nitrous oxide. We know that nitrous oxide has additive effects in terms of MAC with our halogenated anesthetics. So again, if you use nitrous oxide, I know some of you do and some of you do not, you can reduce the amount of Desflurane that's needed as well. For those who choose not to use nitrous oxide, there may be a number of reasons. This is Miles' study of inpatients from Australia, where they showed an increase in nausea and vomiting, wound infection, and atelectasis in inpatient populations. A very large study of several thousand patients. I would point out that with the modern halogenated anesthetics, because the wash-in is quick, the washout is quick, not quite as fast as for nitrous oxide, there's less need for nitrous oxide. Moreover, there's again not the need for overpressurization with Desflurane. So let's look at how Desflurane performs in real-life cardiac surgery, where patients have a base of narcotic analgesia on board, and we actually see, looking at using MAC to control hemodynamics, either with Desflurane or isoflurane. This is at the time of sternotomy. We actually see that comparing Desflurane to isoflurane, that the heart rates in the Desflurane group are actually lower, and at several points to statistically significantly lower than the isoflurane group. Okay? So even though going up above 1 Mac, lower. Why? Because this has been used in conjunction with doses of fentanyl that you see there. So combined with fentanyl, we don't see this problem with tachycardia. And if you were to ask me why do I think the heart rates, and it was also the case that the blood pressures were lower with Desflurane at some points, I believe it may result from the better titratability, less soluble, quicker in, quicker out, makes it easier to titrate the level of anesthesia. There are studies that show this, comparing Desflurane to sevoflurane, better titratability, Desflurane to isoflurane, better titratability. And I believe this is related to the solubility. And in fact, as Professor Jacobson related, we know that the volatile anesthetics are cardioprotective. This is one particular study from Italy that shows that troponin release was reduced in off-pump CABG with volatile anesthetics, and in this study, the volatile anesthetic was Desflurane. So we see here cardiac protection. We know from Miles's meta-analysis in cardiac surgery that patients who receive volatile anesthetics have an easier time of separating from cardiopulmonary bypass, have less troponin release, require less inotropes to come off of cardiac bypass. And what we see here is in one study that you have patients requiring less time in hospital. This is the percentage of patients requiring 7 or more days of hospitalization after coronary bypass. We see that this is reduced in patients who receive Desflurane compared to Ativa with propofol. Certainly shorter ICU times, possibly shorter hospital times, and in one study, less mortality even in patients who receive volatile anesthetics, including Desflurane, compared to sevoflurane. So we've talked about the possible cardiac irritant effects. We say the way to deal with this is to combine with adjuvants, opiates, nitrous oxide, perhaps propofol. Do not go over 1 MAC. In fact, not needing to go over 1 MAC with overpressurization because you reach equilibrium quickly. The same is true for the respiratory effects. And I'll go through some data here. Number one, Desflurane is not indicated for inhalational induction. I will show you some studies of inhalational induction, but it is not indicated for that. However, if you ask patients to breathe without premedication, 1 MAC, Desflurane, or sevoflurane, no one complains of respiratory embarrassment at that point. If you increase the Desflurane to 2 MAC, patients complain. They do not like that. They find that uncomfortable. However, well, I'm sorry, I'll get to this. What we also know is that if we increase Desflurane to 1.5 MAC compared to sevoflurane or isoflurane, we can see increases in respiratory resistance. There are no differences in respiratory resistance at 1 MAC. If you go up to 1.5 MAC, at that point you can see increases in respiratory resistance. Therefore, it is not surprising in studies that if one chooses to use no opiate and uses a laryngeal mask airway, you may see more coughing. But there are any number of studies of laryngeal mask airways that show no difference in coughing by the volatile anesthetic when relatively small doses of opiate, usually fentanyl, are used. In fact, if we look at patients who are induced with Desflurane, not to be recommended, we see that if there is no premedication, 25% of the patients cough. But a small dose of fentanyl, 1 microgram per kilogram, almost eliminates in a statistically significant way the rate of coughing. So again, small amounts, judicious amounts of opiates in conjunction with Desflurane ameliorate the cardiovascular effects, ameliorate the respiratory system effects, and allow one to use this drug at concentrations of approximately 1 MAC. In fact, this is a study from San Francisco in patients breathing either sevoflurane or Desflurane through a laryngeal mask airway. And what we see here is that the rate of coughing was low and was equal between the two groups. However, in this patient population, only a minority smoked. And so the question is, what about smokers? We do know that at 1 MAC, we can potentially see some increase in respiratory resistance at 1 MAC compared to sevoflurane. So it's something that we want to be aware of. And yet, when McKay and colleagues did a study, all in smokers with balanced general anesthesia, Desflurane or sevoflurane at approximately 0.7 MAC end-tidal gas in 50% nitrous, and the average patient received approximately 150 micrograms of fentanyl. So a balanced general anesthetic, 0.7 MAC volatile, 50% nitrous oxide, 150 micrograms of fentanyl, and some of the patients had peripheral nerve blocks because some were orthopedic surgery. In a population where all the patients coughed, the rate of coughing was higher, as we would expect, but we did not see differences between the patients receiving Desflurane or sevoflurane. And we saw that the patients who received Desflurane woke up quicker. In longer surgery, in pulmonary surgery, these are often patients who smoke, and yet one of the advantages of Desflurane in this patient population is more rapid awakening, and as we'll discuss in a few minutes, also the potential for better respiratory function and better airway protection. So if you think that a pulmonary resection is an operation that in my experience may last 3 hours, I like the idea of having an anesthetic that dissipates rapidly at the end of that, leaving a patient with as normal as possible respiratory function at that time. Now, I showed this slide earlier. We see here again that Desflurane does not accumulate much over time compared to sevoflurane or isoflurane, and we want to keep this in mind over the next few slides. This is a study of patients undergoing craniotomy from Italy, and these were patients who were overweight and obese. These were patients with brain tumors where there were concerns about intracranial pressure after surgery, and we see here that the patients who received Desflurane had better PCO2s, more normal PCO2s after surgery than patients who received sevoflurane. This may reflect both more rapid elimination of Desflurane compared to sevoflurane, and also at 0.1 Mac anesthetic, sevoflurane has some respiratory depressant effects. This may or may not translate into faster recovery in the PACU. And this is one study that shows patients who received Desflurane were discharged from the recovery room faster with Desflurane compared to sevoflurane. So patients may be awake at 0.3. We call Mac awake 0.3 Mac. Patients can open their eyes and respond to you. But look at this. This is the fraction of Mac awake. So in point of fact, this is 0.5 times 0.3, or 0.15 Mac. A small amount of anesthetic, residual, at which a patient can talk to you, there's still a significant likelihood of pharyngeal dysfunction. So we're going to talk about recovery beyond just being able to talk to you after surgery, but to have other protective reflexes intact. We know that if patients arrive to the PACU awake, they are less likely to have respiratory complications. If they arrive to the PACU asleep, they are more likely to have respiratory complications, and this increases with age. And what are the mechanisms of pulmonary dysfunction after surgery? One may be residual anesthetic. We know that in elderly patients, the MAC of, in this case, Desflurane, decreases. This is in oxygen with age, and this is in nitrous oxide. So we know that our elderly patients require less anesthetic. One potential mechanism of pulmonary complication is microaspiration. And Rachel McKay also, in her work at San Francisco, did a study looking at recovery of the ability to swallow water. 2 minutes after patients first responded to command, they asked patients swallow 20 cc's of water. I don't think this is something that you normally do with your patients, and it's not recommended. But notice, all of the patients who received Desflurane 2 minutes after their first response to command were able to swallow the water. Only half of the sevoflurane patients could. And this suggests the potential for faster return of airway reflexes in the patients who received Desflurane compared to sevoflurane. Another potential mechanism of pulmonary complications is residual neuromuscular blockade. And one of the things we see here with Desflurane compared to isoflurane is that at low levels, we actually see better return of twitch tension. So not only do the patients with Desflurane eliminate faster, but it appears that their neuromuscular blockade may recede faster as well. So to wrap things up, I will show you a couple of things. Number one, Dexter and his group have done some meta-analyses looking at all of the literature. And when they compared Desflurane to sevoflurane, they see that patients who receive Desflurane are extubated 21% quicker and have less variability, follow commands quicker and less variability. So Desflurane is both faster and more predictable. How about compared the last one was propofol. This is compared to sevoflurane, and we see here the same thing, that Desflurane has more quicker emergence and more predictable emergence as well. I think this slide here really summarizes what we know about the difference in the pharmacokinetics and how this relates to these issues, particularly of potential airway protection and recovery of function in our patients. We know that Desflurane is less soluble. We know that it accumulates less. We know that it's eliminated faster. We know that patients have less respiratory depression afterwards. And we see this here. If we look at the time it takes for patients to swallow after the anesthetic discontinuation, and this is in seconds, all right, so this is approximately 17 minutes here, we see that the times with Desflurane are lower than with sevoflurane. They are predictable. The sevoflurane patients have longer times, less predictable, but look at this. As the time increases, the sevoflurane recovery times to swallowing increase, whereas the Desflurane recovery times of swallowing are independent of length of administration of anesthetic. Thank you very much for your time and attention this afternoon.